Hello dear students, this is Dr. S.P. Nayak. Thank you for joining my lecture. In today's lecture, we will be covering all the concepts regarding insulin. So firstly, let us see about pancreas. Insulin is a polypeptide. It is a hormone which is generally synthesized from the beta cells of pancreas, and this insulin has a wide variety of roles in metabolism as well as in synthesis of proteins and many other physiological functions in the body. So let us see about pancreas. Pancreas is a mixed gland. Pancreas is a mixed gland which is present just below, just sideward to our stomach, and this pancreas has a leaf-like structure, and this pancreas is a mixed gland which has exocrine part as well as endocrine part. So we have exocrine tissue and endocrine tissue. Endocrine tissue, and the exocrine tissue synthesizes many enzymes like pepsin, trypsinogen, trypsin. All these enzymes are synthesized by exocrine part of the exocrine part of the pancreas, and they will be transported to the stomach. And these exocrine hormones are utilized for the digestion purpose. And the cells which synthesize this exocrine part are called duct cells, acinar cells, and some other cells. And when we talk about endocrine part of pancreas, we have 4 different types of cells. We have alpha, beta, delta, and gamma. Not gamma, it's F cells. So we have 4 different types of endocrine. So the endocrine part of the pancreas is called islets of Langerhans. So these islets of Langerhans is present in the interior part of the pancreas. So these are the different types of islets of Langerhans. The alpha cells of pancreas synthesizes glucagon, and beta cells synthesizes insulin. Delta cells synthesizes it synthesizes somatotropin. Sorry, it's not somatotropin, it's somatostatin. So gamma cell synthesizes somatostatin, and the F cells synthesizes pancreatic polypeptides. So these are the different types of pancreas cells of the pancreas, and alpha cells synthesizes glucagon, beta cells insulin, delta cells somatostatin, and F cells synthesizes pancreatic polypeptide. This F cells which synthesizes pancreatic polypeptide is utilized for management and synthesis of all other hormones in the pancreas. And everyone should understand here, the delta cells which synthesizes somatostatin, it is different from somatotropin. Somatotropin is a growth hormone, whereas somatostatin is an anti-growth hormone. So this you have to remember this point. And insulin is synthesized from beta cells, which has a major functions. Anyways, we will be covering about insulin in the further classes. And alpha cells synthesizes glucagon, which has opposite actions of insulin. So this is about pancreas, different cells in the pancreas, and what they synthesize and their roles. So now let us see the regulation of insulin. How insulin is regulated in our body. Regulation. Insulin is regulated mainly by 3 factors. The first one is chemical regulation or chemical factor. The other one is neuronal factor, and the third one is gastric or gastrins. It is also called incretins. So listen carefully. Insulin is generally especially regulated by chemical factors. That means when a body increases the levels of glucose, fatty acids and amino acids, when a person's blood increases all this glucose, fatty acids and amino acids, all this influences the beta cells in the pancreas to increase its synthesis. This is one factor. And the neuronal factor which increases beta cell stimulation is, we have sympathetic and parasympathetic nerves which are innervated to the pancreas. They also have the activity of increasing or decreasing the synthesis of insulin from the beta cells. So even they will regulate the synthesis or inhibition of insulin from the beta cells. And the third one is incretins. See, when a person consumes food or any nutraceutical items through GI tract, our GI tract releases some special hormones called incretins. Among them we have GLP-1, which is also called glucagon-like peptide. We have GIP, and we have CCK, and we also have secretin, gastrin, and we have many other incretins. All these hormones which are present in the GI tract, which are secreted from the GI tract, they will influence the beta cells to increase its synthesis. So this is the regulation of insulin. Now let us see what is the mode of action of insulin. So, because of all these factors, anyways, insulin is secreted from beta cells, and insulin synthesis has a huge mechanism. Anyways, we will not discuss the internal mechanism, how insulin is getting secreted from the beta cells. Now we will see the mode of action. Mode of action of insulin. So this is very, very important concept. Consider this is a cell membrane of any, this is a typical cell membrane, and every cell membrane has insulin receptors. So insulin receptor is a tyrosine kinase receptor, and we have many types of receptors. Among them, tyrosine kinase receptor is one type. This is a tyrosine receptor. It has alpha 1, alpha 2, beta 1, beta 2. So we have 4 different regions of insulin receptor. And when insulin is released from the beta cells of the pancreas, this insulin comes and binds on this receptor. So after binding on this receptor, this insulin receptor will be phosphorylated. It undergoes phosphorylation. That is called autophosphorylation. So insulin receptor gets phosphorylated and it synthesizes insulin receptor substrate 1. So after activation of the insulin receptor, it activates or it synthesizes insulin receptor substrate 1, which is very, very important precursor or important chemical mediator for the functions of insulin. So after its stimulation, these again will be phosphorylated. This will be autophosphorylated and it tries to activate PIP3. So IRS1 activates PIP3, and this PIP3 is helpful for the cell survival. So insulin is helping for the cell survival. That means insulin reduces the time period of the death. The time period of cell death. So it reduces necrosis. It reduces necrosis. So this is one function of IRS1, and this IRS1 activates GRB2. This IR1 activates GRB2, which further helps in proliferation of cell. So insulin activation is helping in cell proliferation. That means it is helping to regenerate or to increase the division of the cell. So it is increasing the proliferation of the cell. So this is another help of the insulin. And the next function of insulin is also activating phosphokinase C. It increases phosphokinase C, and further this phosphokinase C increases the production of GLUT4. This is very, very important. So insulin helps in the production of GLUT4. GLUT4 is nothing but glucose transporter. So every cell requires glucose transporters to increase the entry of glucose from these transporters. So insulin helps in the synthesis of GLUT4, and this GLUT4 is again comes and it is concentrated on the cell membrane, and this GLUT4 helps the entry of glucose from the blood circulation. So in this way it helps to increase the movement of glucose from the circulation. And the other thing it helps is insulin, and the phosphokinase C also increases it causes many actions on liver. So we'll see in detail about the actions of liver. In the liver, insulin helps to increase the production of glycogen. That means the conversion of glucose into glycogen. That is one action, and it reduces production of glucose from liver. So it reduces production of glucose from the liver, and it causes protein synthesis. So these are the major functions of insulin on the liver. So this is about the mode of action of insulin, and in this way finally the insulin reduces the glucose content in the blood. So it helps in hyperglycemia. So these are the functions of insulin in the body. Now let us see insulin preparations. So we have to concentrate on insulin preparations. Actually, it is very important for us to prepare insulin because insulin is very much useful in diabetic conditions, especially in type 1 diabetes. Type 1 diabetes is a condition where the pancreas, beta cells of the pancreas stops production of insulin. So in these patients, we require insulin from the external route. That is the reason we have to synthesize insulin. So in previous days, we used to synthesize insulin from pork, and that insulin is called porcine. And we also used to synthesize insulin from bull. It is called bovine insulin. So the insulin which is synthesized from bull and pig, they have a special tissue on the insulin molecule. So this has a very bad adverse effect. So that causes hypersensitivity. However, the insulin or any other hormone which is synthesized from other animals, and these insulin or that substances which are administered into the human beings, they will act as foreign bodies. And when the foreign body enters into our body, our own white blood cells and some antibodies will be activated, and they recognizes that this is a foreign body, and they will try to fight against those antigens, and it causes hypersensitivity reactions. So nowadays we are not using the insulin which is synthesized from pork and bull, and now we are synthesizing the insulin called human insulin. So human insulin is generally synthesized by using rDNA technology. So recombinant DNA technology. So nowadays we are using human insulins. Now let us see the classification of insulin. In the classification, we have 4 different classifications. The first one is, we have ultra short acting insulin. Ultra short acting insulin. And in this insulin we have glulysin, we have aspart and lispro. So we have lispro, aspart and glulysin as ultra short acting, and we have short acting insulins. In short acting insulin we have regular insulin, which is very commonly used insulin, regular insulin. And in some textbooks you can find short acting, intermediate acting and long acting. However, I am differentiating short acting into ultra short and short. And the third one is intermediate acting. So in intermediate acting we have NPH. And finally we have long acting insulins. In long acting insulins we have glargine and ditimer. So for easy understanding, let me tell you. You can remember it as GAL or LAG. Let me remember it as LAG. So lispro, aspart and glulysin. So these are short acting insulins, and the general duration of action of these ultra short acting insulins is 3 to 4 hours. So they have a rapid onset of action, and their duration will be up to 4 hours, and they will be excreted within 5 hours. And in short acting, however, we have only one insulin, that is regular insulin. So its duration of action is around 6 to 8 hours. And in intermediate acting also we have only one insulin, that is NPH, and its duration of action is between 10 to 20 hours. And long acting insulin's duration of action will be 20 to 24 hours. This is very important. So however, in ultra short acting insulins, the chemical structure and the presence of these amino acids and their placement will be different. By that action we can have these insulins as rapid acting insulins, and short acting insulin is a regular insulin. No changes are made in this insulin. And NPH insulin is a neutral protamine hagedron. So it is a neutral insulin. It is not acidic or not basic. It is a neutral, And this intermediate acting NPH insulin is it is like a milk like structure. I mean milk, it is, we can observe it as a milk. So it is not clear, it is not like water, but its physical structure is like milk, cloudy. It is cloudy in nature. So that is NPH. And regular insulin is very clear and it is like water. And glargine and D-dimer are rarely used. However, they have a long duration of action and every day one dose is enough. And we have some special pen injectors where we use glargine and D-dimer as long-acting insulins. And one thing we have to remember from this glargine and D-dimer, we should not mix these insulins with other insulins. We can mix intermediate acting insulins with the others, but long-acting insulin should not be mixed with other insulins. And they are acidic in nature. And here D-dimer is a fatty insulin, and it's releasing after administration. This insulin will release very slowly from subcutaneous route. So because of that reason, it has a long duration of action. So this is about classification of insulins and duration of actions and their different types. So let us see the different modalities of insulin therapy, how insulin therapy is given to the patient. Generally, insulin is given in type 1 patients. However, type 2 patients also receives insulin, especially in emergency conditions. We can administer insulin. And mostly type 1 patients receives insulin. First thing we have to understand few concepts about insulin is, first one, insulin daily dose. The first thing, what is insulin daily dose? Insulin daily dose is nothing but amount of insulin which is required by a patient per day is called insulin daily dose. So it can be calculated by using a simple formula, that is 0.5 to 0.7 into body weight. Generally, this formula is followed to get the insulin daily dose. So why this range is followed? Because in small children we have to use 0.5, and in obese, and when the body weight keeps on increasing, we have to increase the range. So in children, those whose body weight is less than 30, we should use 0.5 into body weight, into weight. And the body weight who has between 30 to 60, we should use 0.6. And the patients who has body weight greater than 60, we have to use 0.7. And if the body weight increases to 110, 120, 130, in those patients, we sometimes we have to use up to 0.8 also. So by increasing of the body weight, we have to increase the point range to calculate the insulin daily dose. For example, a patient is having body weight of 30 kgs and we have to calculate his total daily dose. So 30 into 0.5 is nothing but his total daily dose. So what will be the answer? So it will be 15 units. Yes, it will be 15 units. So 15 units for a patient who has 30 kgs of body weight, his total daily dose will be 15. So he requires 15 units of insulin for whole day. So we have to calculate the dose from the 15 units. So in the morning we have to prescribe 5, 10 units. Depend on the other, we have other principle. How should be insulin given in the morning dose, afternoon dose, and how should be given in the night dose. So this is about insulin daily dose. And next principle of giving insulin. So everyone should concentrate here. Generally, a patient is given insulin in the morning dose and in the evening dose. So from the total daily dose, in the morning we have to administer 2/3 of the total daily dose, and in the evening we should prescribe 1/3 of the total daily dose. So this is the principle we have to follow. And in the morning dose, which insulin is given as morning dose? So we have ultra short acting, intermediate acting, and long acting. Which one will be given? So for this we have another principle. We should give long acting insulin and short acting or intermediate acting. We can give short acting or intermediate acting, or generally we give short acting. Here long acting is not required. Here we have to use intermediate acting. This is intermediate acting and short acting. So intermediate acting insulin should be given 2/3, and short acting should be given 1/3 from the morning dose. So among the total daily dose, we concluded that a 30 kgs of body weight patient has total daily dose of 15 units, and from these 15 units, 2/3 of the morning dose is 10 units. It will become 10 units. So 10 units is 2/3, and the evening dose should be 1/3, and that is 5 units. So from these 10 units, intermediate acting should be 2/3 and short acting should be 1/3. So what will be the 2/3 from the 10? That is, it will be around 7, and 1/3 will be 3 units. So 7 units of intermediate acting and 3 units of short acting should be mixed and should be given as morning dose for the patient who has 30 kgs of body weight. And in the evening dose, here we should give intermediate acting half dose and short acting half dose from these evening dose. So intermediate acting half is nothing but 2.5, or for better understanding, make it 6 units. So 3 units of intermediate acting and 3 units of short acting. Total 6 units should be given in the evening. So this is about dosage regimens of insulin which should be given to the patient. And for better understanding and for better convenience, in the market nowadays we are having 70/30 pre-mixed insulins. Pre-mixed insulins are available, and we also have 50/50 pre-mixed insulin. So 70/30 is nothing but this is a morning dose, and 50/50 is nothing but this is a evening. This is morning insulin and this is evening insulin. So a patient with 60 kgs, let us assume a patient with 60 kgs, his total daily dose will be around 60 into 0.6. It will be around 32 units. So around 32 units, let's suppose. So 32 units is the total daily dose of a patient who has 60 kgs. And his morning dose will be 2/3, that is 2/3 means it will be around 20 units, and his evening dose will be around 10 or 12 units. So 70/30 type of insulin should be given in the morning, and 50/50 should be given in the evening dose. So 20 units should be given 70:30 type of mixed insulin, and 50/50 premixed insulin should be given 12 units, and this should be given in the night. So no need to take intermediate acting insulin, short acting insulin. Here intermediate is nothing but here we have to take NPH, and short acting here we have to take regular. So we have to take regular and insulin, mix both the insulins and make it the total daily morning dose and inject the dose which should be given in the morning. And here also the same, the intermediate acting we have to take NPH, half of the dose 3 units, and short acting regular should be taken. In short acting you can also take ultra short acting drugs like Lispro, Aspart or anything but for more compatibility and more effectiveness we generally use regular insulin. However, it has same duration of action. So they both should be intermixed and they are given in the morning dose and evening dose. So this is about insulin dose calculations. So next let us see adverse drug reactions of insulin and drug interactions. Now let us see the drug interactions, insulin drug interactions. We find only few drug interactions with insulin. The first thing is drug interactions with beta blockers and insulin. When insulin is given and beta blocker is given together, sometimes in hypoglycemic condition, in the overdose of insulin, in hypoglycemia, patient will have sympathetic activity. So patient will have tremors, shivering, and patient will have syncope, all these reactions. That indicates that patient is having hypoglycemia and immediately he should take some glucose materials to compensate that hypoglycemia. But when this patient is taking beta blockers, they will mask the sympathetic activity. So beta blockers will mask the sympathetic activity and it will stop all these shivering symptoms. That indicates that this patient has no hypoglycemia, but patient will have hypoglycemia, and that will cause lethal consequences, and severe hypoglycemia is very dangerous and it may cause coma also. So this is severe drug interactions we have to remember. And the next one is salicylates and insulin. So when a patient is taking salicylate will increase the synthesis of insulin from the body and they will increase the sensitivity of insulin, and that may cause severe hypoglycemia. So this is another interaction of insulin. So while giving salicylates and beta blockers, we have to remember this point. And any patient who is taking insulin and sulfonylurea is another oral antidiabetic drug that causes increased, generally it is seen in type 2 diabetes. Type 1 diabetes, sulfonylureas has no effect. And in patients who are taking sulfonylureas like glimepiride and insulin together, sulfonylureas will cause insulin release from the pancreas, and the insulin which is already given, they both causes severe hypoglycemia. So patient will have coma. So this is another interaction about insulin. So let us see adverse drug reactions, ADRs of insulin. The first and foremost very important ADR of insulin is hypoglycemia. So hypoglycemia is very common with insulin. So we have to keep on checking the hypoglycemia of the patient. And sometimes patient will have hypersensitivity. Most of the patients who receive recombinant DNA insulin, they will not have this reaction, but some patients will have this reaction. So this is rarely seen. However, we have to study in ADRs. And sometimes patient will have patches and some cellular dysfunction of the adipose tissue by regular concurrent and continuously taking insulin injections on the thigh and on the adipose tissue. So that may change its physiological nature, adipose tissue size, and it may have some alterations. So always we have to keep changing our insulin site of injection. So this will reduce this symptom. And the other ADR that causes is usually seen by insulin is insulin increases body weight. So this is another ADR with insulin, and these are common ADRs which are seen with insulin. So this is about insulin. In next class we will see what is insulin to carbohydrate ratio and correction factor, and how insulin is calculated in type 2 diabetic patients, and in hyperglycemia how much insulin dose should be given. And if any patient who is immediately they have to any diabetic patients who has to be taken to surgery, and we have to reduce his or her glycemic level, so how much units of insulin should be given. So all these concepts we will see in the next class. And in this lecture I think we have discussed about insulin, their mode of action, how insulin is released, regulation of insulin, pharmacological actions, insulin preparations, different types of preparations, classifications, and different formulations and commonly uses of insulin, their interactions, and adverse drug reactions of insulin. So thank you for watching. We'll meet in the next class.